presentation this morning is entitled Balanced Resuscitation with Whole Blood versus Component Therapy in Severely Injured Pre-Adolescent Children. It will be presented by Dr. Robert McLaughlin.
Good morning. We have nothing to disclose. Trauma is the leading cause of death in children ages 1 to 19 years. Of those deaths, almost a third are associated with hemorrhage. In one study of children presenting to an emergency department found 13-fold increase in children with hemorrhagic shock and hypotension compared to those who were normotensive. One has several options for resuscitation for hemorrhagic shock, including whole blood and component therapy, in which each individual component of blood is given independently. Whole blood is well studied in the adult and military settings for both efficacy and safety, and there's a growing body of literature in the pediatric realm. Additionally, there's large interest, with over 2/3 of responding level 1 pediatric trauma centers indicating an interest in starting a whole blood transfusion program or having already done so. However, the existing data has a large proportion of adolescents. But what about the younger children? And what about the timing of the blood products? Our aim was to compare balanced resuscitation with whole blood versus component therapy in a large cohort of critically injured pre-adolescent children. We utilized the ACS TQIP database for the years 2017 to 2019 to identify children under the age of 12. Our primary endpoint was the time to balanced resuscitation, which we defined as either receiving whole blood or all three components of blood in component therapy. Our secondary endpoints were the number of transfusion exposures, ICU length of stay, and mortality. We had identified 390 children, 281 in the component therapy and 109 in the whole blood. They were similar in demographics. These were severely injured children with a median ISS of 30. 72% presented to the emergency department with abnormal hemodynamics, and 25% had experienced pre-hospital cardiac arrest. Overall, 77% were cared for at an ACS-verified trauma center, but this differed slightly between the two groups. We used a Kaplan-Meier analysis to assess our primary outcome, which was time to achieving balanced resuscitation. The median time in whole blood was 28 minutes, and in component therapy, it was 87 minutes. This resulted in almost an hour quicker achieving balanced resuscitation in the whole blood group compared to the component therapy group. When breaking out the data by key time points, we found that 35% of children in the whole blood achieved balanced resuscitation at 15 minutes compared to component therapy at which was 4%. At the golden hour, it was 72% and 32%, and at 3 hours, it was 96% and 88% respectively. Next, looking at our secondary outcomes, I want to draw your attention to the mean number of transfusion exposures and the time to ICU discharge. The children in the whole blood group had fewer transfusion exposures and had shorter lengths of ICU stay. There was no difference in mortality. In conclusion, in this cohort of critically injured pre-adolescent children receiving emergent blood transfusion, whole blood was associated with faster time to achieving balanced resuscitation, fewer transfusion exposures, and short ICU stays. There was no difference in mortality. Prospective studies in the future should focus on the optimal use of whole blood in pediatric trauma patients, and this is a good avenue for further investigation. Thank you.
Paper's open for questions. How has your program implemented this so far, or have you?
We are in the process of setting up a whole blood transfusion program.
Okay, and how are you coordinating with the blood bank, or?
Sorry, say that again?
How are you coordinating with the blood bank?
So our aim is to have two units of whole blood in the pediatric trauma bay at all times. And so some of the challenges have been maintaining more equipment-based and maintaining the temperatures and things like that. It's more kind of logistical than it is anything else.
Romy Ignacio, San Diego. Great study. I liked the fact that we're seeing this in younger children because the adult literature clearly shows there's a benefit. But I think some of the dilemma for some pediatric centers, there are some urban centers that transfuse quite a bit and some that don't. Can you comment about the cost versus the benefit? Because some centers are not going to want to invest in whole blood if they don't use it very often. So that's one component. And then two, there's some recent literature that shows a correlation between the amount of volume that you give directly relates to the benefit. So if you look at those centers that give a low amount of resuscitation versus those at high volume, there's definitely a difference between those two, and that recently came out from Journal of Trauma. But thank you, great presentation.
Thank you. So in regards to volume, so we did see a reduction in volume. It was on one of my slides. In the component therapy, I think it was 82. I can actually go back to it at maybe. Oh yeah, this slide. So there's 85 cc's per kilo in the component therapy and 50 cc's per kilo in our whole blood. So there is a difference there. In discussing with our hematology colleague who's helping us with this paper, the number of transfusion exposures was the more important thing for them in terms of risk of Charlie and Taco. But in terms of volume, obviously that is a big concern. We didn't see an impact of that on outcomes, but we haven't then done a sub-analysis looking at volume, so it's certainly something we could consider. Thank you.
Thank you.
Thank you. That concludes this session.